So today, this session is with residents from both orthopedics and our general surgery team also. So before I move ahead, I just want to introduce a little bit more about myself. That I am primarily an orthopedic surgeon. I was trained in orthopedic surgery from Chennai, and then I moved into orthopedic oncology. The term orthopedic oncology, I feel, is a bit closed. It's the better word would be musculoskeletal oncology because it deals with various aspects of musculoskeletal diseases. So we will discuss what is the scope for further being training into musculoskeletal oncology. What are the different types of cases that we see, what we do, what we practice, and some of the basic myths and facts, which I feel is very, very important because I work in a very big team here. And even I realized that when I came out of Tata Memorial Hospital, even at best of the centers, I would not say that the knowledge was less, but probably the outcomes related to tumors were considered very dismal. But things have changed a lot, and we'll see how we uh, how the things have changed. Before I move forward, let me tell you, in musculoskeletal oncology, we primarily deal with bone tumors, soft tissue tumors, metastatic bone disease, and many other things. In the tumors, benign tumors are much, much more common than sarcomas. Another aspect why MSK oncology is very rare because the sarcomas are just 1 to 2% of all the malignancies. Another interesting fact I want to share with you that when I came out of Tata Memorial Hospital, Mumbai in 2015, when I was planning to come to Delhi, start the work, even I was not sure because uh, if we checked out how many hospitals are there which have a dedicated unit, so there was none. Just one in AIMS, it had an institution where it was run, but in a private setup, there was no dedicated orthopedic oncology unit in any corporate hospital. So even I was not sure whether they will give me a job or not. But somehow the chord struck well between the oncology team, and I was given a department to start with. And it started in a very humble way. First month I did 2 or 3 cases. Second month also similar like that. But currently, in a month, I'm operating around 15 to 20 sarcomas, which are malignant tumors of the bone. And we are now 2 units, and we have a fellowship program. Every year, we have 2 fellows with us who are under training. And currently, the fourth batch of fellowship is going on. So, so it is a gradual evolution once people realize that sarcomas or musculoskeletal tumors are a different specialty which needs a separate specialty to treat. That's how things have developed over the time and has shown the evolution. So that's one of the reason why there are few centers in India which have this dedicated unit. If we talk about like that, we have like you have AIMS, you have Tata Memorial Hospital, you have in Adyar Chennai Cancer Institute, or Rajiv Gandhi, or you have GCRI in Ahmedabad. So these are a handful of institutions. There are some more I cannot name, but there are only handful of institutions where this specialty and exclusive dedicated unit is being practiced. And the reason being, not many hospitals have this because the number of tumors are very less. These are less than 1% of all cancers. So during our training, whether it is general surgery or whether it is orthopedics, we see really very, very less number of cases throughout the 3 years of training that we are. So the correct protocols which are required, it is missing. Many a times, or mostly I would say in government colleges, when the patients are seen with bone cancer, they are advised amputation, and that's how it ends everywhere. Unless we have a complete team set up, which includes your medical oncology, radiation oncology, it's difficult to give optimal treatment to these malignant cases, and that's why the overall uh, picture that has framed into people's mind is that if there is a bone cancer, nothing can be done. It's just amputation, and even if you do that, patient is not going to survive. So I'll not go too much into the theoretical aspects, but just quickly I will tell you that these sarcomas are very, very rare, and there are more than 100 of histological subtypes. When, as a practitioner, many times when we talk, normally we call soft tissue sarcomas as a single entity, but there are more than 100 different types. And it is important. That's how the development has occurred that in pathology and other things. We are moving not just from the microscopic diagnosis, what we see, but through in further immunohistochemical markers or through different translocation studies that we specify which type of sarcoma, because it determines the chemotherapy, it determines the prognostic outcomes, and even sometimes the surgery, whether it's a low grade, high grade radiation therapy, etc. So when we talk about orthopedic oncology, this is the common feeling what we have to my orthopedic residents, that it deals with bone and soft tissue sarcomas. But if I really talk about it, the bone tumors can be benign, like you have aneurysmal bone cyst, simple cyst, uh, GCT, giant cell tumors, and malignant tumors like sarcomas, osteosarcoma, Ewing sarcoma, chondrosarcoma, malignant fibrous histiocytoma, etc. The soft tissue tumors, mostly that we see are sarcomas, and many times benign lesions are also there, like locally aggressive ones like fibromatosis. You have then atypical lipomas. 40% of the cancer at one point of the time, they metastasize to bone. So these also constitute a subgroup of our patients. Many times the tumors which were treated with open surgeries like aneurysmal bone cyst, chondroblastoma, can nowadays be treated with simple, minimally invasive techniques. Like just with simple needle insertion, we can inject steroid or polydoconol, a sclerosant agent. We can do radiofrequency ablation in chondroblastoma, in osteoblastoma. For these procedures, I remember when I was doing my post graduation, my bosses used to resect uh, for osteoblastoma complete bone. The entire bony section was resected, and then we have now developed newer modalities like burying the nidus, etc. Because of the exposure in orthopedic oncology, we are uh, habitually we are trained to deal with vessels and nerves. Unlike in routine orthopedic training, where it is taught that you have to be in the internervous plane, which means you follow the plane where you don't find the vessels or nerve, you are between two different group of muscles and you reach the bone directly. The approach in oncology is totally different. Here, you need to find out the plane where you see the vessel, you see the nerve, you identify and protect them, separate it out, and then remove everything as a margin along with the tumor. So many times, my friends and my colleagues from orthopedic department, they ask my help in complex defect reconstruction, especially sometimes in gunshot injury, blast injury, where entire segment of the bone is lost. In infective cases, entire bone is lost, and where we need to put megaprosthesis. In such scenarios, the specialty, the training in orthopedic oncology is very handy. Like I was talking about the myths and facts. So one of the biggest myths that we face today is that biopsy increases the tumor growth. Even many a times when I see a tumor, my colleagues ask me from the orthopedic, or even a soft tissue tumor is there, my surgical colleagues ask me, why to do a biopsy? Finally, we need to remove it, and biopsy might increase the tumor growth. So I would say it is a myth that biopsy increases the tumor growth. In fact, biopsy is mandatory to establish the diagnosis before you start the treatment. Normally, the tumors, they follow a exponential growth pattern where one cell divides into two and two into four, and that's how it exponentially grows. By the time they reach a certain size, say 2 centimeter, the next doubling time it is going to become 4 centimeter. So whether you do or you don't do a biopsy, it is going to increase in size. Second fact, that if the biopsy is not done properly, if as a surgeon we are not trained to do the biopsy, that is the scenario when a improper placed biopsy scar or uh, inadvertent contamination of compartments can lead to tumor growth. Otherwise, if you are trained, and I'm sure that with throughout this journey of conceptual, whether it is orthopedics or surgical, you all are going to be thoroughly trained, and you will be very much following the principles, and you it will be again and again emphasize how to do a right biopsy. You all will be able to do a good job. So this is a myth, and what we say that biopsy is always important to confirm the diagnosis. And unlike traditional way of doing open biopsy, we prefer a core biopsy. So this is the traditional method where you open this scar, and nowadays we use this Jamshedi needle in bone or true cut biopsy needle in soft tissue. One stab incision, 11 number blade. Patient can go walking the way he came, and done under local anesthesia. So this is just I'm showing you how we do that in an acetabulum supraacetabular region. There is a lytic lesion. We put in the guide wire and just use this Jamshedi needle